Good morning, everybody. Thank you for inviting me to this session. I am a radiologist, one of the few probably in this conference. I will talk about strategies regarding MRI and arthro MRI of the shoulder. I will start by talking about strengths and weaknesses of the MRI technique. Then I will talk about my strategy imaging the shoulder with MRI, and I will show you a decision tree. I will answer some questions like which is better, MRI or arthro MRI, or how to choose between direct or indirect arthro MRI, and I will show you some examples. About strengths and weaknesses of the MRI technique, you know that MRI is very good for bone and soft tissue characterization. It is very good because it has a good tissue contrast resolution. It discriminates very well between different kind of tissue. You can see here all the structures. You can see the bone, trabeculae, you can see calcification, you can see tendon fibers, you can see fluid in a subacromial bursa, you can see a labrum, and you can see cartilage. Nevertheless, you know, it's a non-ionizing technique, so it's harmless for the patient. But it has some downsides like long examination time, around 30 minutes, which make it prone to movement artifacts. You cannot interpret something like that. Also, MRI is prone to artifacts from metal implants, or it has contraindication when there are non-compatible metallic implants or the patient is claustrophobic, and spatial resolution is less than CT or ultrasound, but don't worry, we are working on that. And it is, of course, an expensive technique. My strategy when I image the shoulder with MRI. First, I read and understand the referral note from the orthopedist. I discuss with the patient about his problem and I try to understand his main complaint. I study previous imaging, X-ray, ultrasound, CT, other MRIs. I decide what kind of MRI the patient needs. I acquire the best possible image study with best technical parameters. I communicate a preliminary impression to the patient at the end of the examination, and then I study the images and write a detailed and final report. If there are any unusual findings, I communicate this via phone or email to the referral doctor. I will skip directly to this step, decide what kind of MRI the patient needs, and I did this decision tree for shoulder MRI. First decision, or decision number 0, is if the patient has a major MRI contraindication like non-compatible metals, claustrophobia or others, he cannot do MRI, so we must find another way of imaging the shoulder. If the patient has no contraindication for MRI, then we are taking into account the presumptive diagnosis, the history, the clinical information, and of course the referral, and we decide what kind of MRI the patient needs. If there is a tumor, we will do MRI with contrast, IV contrast. If there is a reumatological disease or the previous MRI is inconclusive, then we must choose between contrast MRI, IV contrast MRI, or indirect arthro MRI, which will give us some information, better information. If we choose to do a non-contrast MRI, we choose to do a non-contrast MRI in most of the cases. When it is a first MRI in the absence of specific diagnosis, or we have no clinical or history available, when there is a chronic pain or recent trauma, but keep in mind that a major fracture, the CT will be better because it is faster and the patient could not stand the MRI examination. In degenerative disease, but X-ray could be enough, or in calcific tendonitis, ultrasound might be better, but nevertheless we do non-contrast MRI. And when there is micro or micro instability, a suspicion of slap lesion, Bankart lesion, labrum tear, or cartilage lesion, we do arthro MRI with this possibility of doing indirect or direct arthro MRI. I will explain this a bit later. But first decision is between non-contrast MRI or arthro MRI. This part of the decision tree we already discussed. So when to use arthro MRI? My opinion, only when information obtained could potentially change the treatment or outcome of the joint pathology. Why is that? Because non-contrast MRI answers to almost all major questions about the shoulder, and arthro MRI increases specificity and sensitivity for some lesions. And also, although it offers this higher sensibility and specificity, I think we should justify the cost, because of course everybody wants better images, better diagnosis, but when you get, maybe 10% a better image or 10% better diagnosis, but the cost is 100% more, so maybe we should consider this twice. Non-contrast MRI, I will start with some example. This is a greater tuberosity fracture. You see very well the fracture, the fragments, the location, just a little displacement upwards here. You see fluid in the subacromial bursa, you see fluid inside the joint. Would you give contrast or would you do arthro MRI for this? No, it's not useful. The patient is already in pain, so this is enough for the diagnosis. This is an old supraspinatus tendon tear. You see the upward migration of the humeral head. There is no supraspinatus tendon. There is huge atrophy of the supraspinatus muscle belly. Would you give contrast or do arthro MRI for this? No, it's not necessary. Would you do arthro MRI for this osteoarthritis? I don't think so. You see very well there is a completely lack of cartilage, loose bodies inside the joint. There is already fluid inside the joint, so you don't need to inject any more fluid. You see huge geodes, and if you do an ACT, you see osteocondensation and huge osteophytes. So you don't need arthro MRI for this. Also, you don't need arthro MRI for this. This is a recent trauma, an avulsion of bone fragment from greater tuberosity, which migrated in the subacromial space. You see there is fluid, there is inflammation, and because of that you can see very well there is an avulsion of EJHL from the humeral head, so this is a Hagel lesion. So you don't need contrast for that. Also, you don't need contrast for this posterior Bankart, which is recent. You already have fluid inside the joint. You see very well contusion, bone contusion, a reversed heel sacs. You see modification of the posterior labrum. You see capsular tear in the axillary recess and a huge tear in superior labrum and extension to the bicipitolabral anchor or slap lesion. So you see very well all this. You don't need contrast. For calcification, you see very well calcification here because they are huge. If they are small, they are more difficult to see, but the ultrasound would perform better. But nevertheless, you don't give contrast for calcification. Some example from arthro MRI, when to use arthro MRI. This is a slap lesion. You see this slap lesion on native or non-contrast images, but if you give contrast, you will better appreciate, characterize this lesion, and the orthopedist will see it better, and this is how it works. This is a Bankart lesion with some cartilage lesions nearby. It's a glad lesion. You see the fissure of the bone fracture. You see fluid that we injected, and because of this fluid, you see very well this cartilage lesion. This is another form of Bankart lesion, Perthes type, with periosteal stripping of anterior labrum, and because we injected fluid into the joint, we can see this fluid going into this stripped area, and you can also see chondrolabral uh, damage in this area. This is a non-specific indication for arthro MRI, but there is a concern. There was some concern from this Latarjet procedure that there is not healed properly here, and there could be some problems with the glenoid enhanced surface. But when we did the arthro MRI, we can see that this gap is filled with fibrous tissue, and it is quite smooth, and there is no extravasation of fluid outside the joint, so it is good outcome. The second decision we need to do is between indirect arthro MRI or direct arthro MRI. So what is this? This direct arthro MRI means percutaneous intraarticular injection with contrast, which distends very well the joint, and you can control the exact quantity of fluid that you inject, and there is less gadolinium dose. But this is a more invasive maneuver. There is potential of injection outside the joint and might increase the time pre-MRI. And of course, there does not offer information regarding enhancement of the tissues, which would be great if we have a tumor or some rheumatological disease. With indirect arthro MRI, we give contrast intravenously, then 20 minutes of exercise with that joint, and then MRI. It's less invasive, decrease the time pre-MRI because it's only a vein puncture, no organizational issue, no caps, but the downside is no capsular distension. The quantity of contrast inside the joint is not constant. How does it look? And direct arthro MRI here, like a page in the book, you see everything. You see labrum, you see posterior labrum with a tear here, you see cartilage very well, cartilage lesion here, you see bicipital tendon and potential slap lesion, you see distension of the joint. Indirect arthro MRI images are not so pretty, but you can see enhancement of acromioclavicular joint capsule. You see enhancement of subacromial bursa synovium, and if there is fluid inside the joint, the fluid will enhance and will better see labrum and cartilage lesion. Regarding the technique about indirect arthro MRI, or already told you, it's just an intravenous contrast injection and then exercise. With direct arthro MRI, I prefer to use ultrasound guidance technique because I'm a radiologist. I use the posterior approach. I visualize very well the posterior glenoid and labrum. I inject avoiding them, and it is fast, it is safe, and there are no disadvantages. With fluoroscopy guidance preferred by some radiologists and most of the orthopedists, the injection is under fluoroscopy guidance. First, you need to inject iodine to verify the position of the needle tip, but the disadvantage is that it is time consuming. You need to book two rooms, the fluoroscopy room and the MRI room. And another problem is irradiation, because you transform a non-irradiating technique like MRI into an irradiating one, which is fluoroscopy. And you can inject by clinical guidance. This is something that our colleagues from orthopedists are doing, not us radiologists. Regarding arthro MRI protocol, this is something you need to understand. Arthro MRI, in fact, is only T1 sequences, T1 with fat set, because on T1 everything is gray or black and the contrast is white, so you very well see every kind of fissure, every kind of cartilage defect. But because sometimes we do not have another MRI, a previous MRI, and because we could miss some pathology, we use some other sequences, and these sequences are fluid sensitive. T2 or PD sequences are fluid sensitive, which means that the fluid is bright, so you can appreciate the bone marrow edema, which you could not appreciate on arthro MRI sequences, and also you can use some volumetric sequences, which offers you a very good spatial resolution. Remember that arthro MRI is not only about anatomy. We don't only appreciate the anatomy. It's important, of course, but we also interpret some physics. We interpret signal changes in the tendon, signal changes in the bone, signal changes everywhere. So in the end, please remember to use arthro MRI only when information obtained can potentially change the treatment or outcome. And remember that MRI is not only about anatomy but also about physics. Thank you for your attention.